Welcome back. I'm Mabel John. You're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. And a special welcome to those of you who are joining us via live stream. Well, we have in our studio this morning Dr. Paul Grundy, who is Chief Medical Officer and Director Healthcare Transformation, Healthcare and Life Science Industry at IBM. Good morning, Dr. Grundy.
Good morning. It's a pleasure to be with you.
Good morning. And we are going to be addressing some of the things that you talked about on your panel. Can you give me some of the key takeaways you thought people should have with them?
On the panel today, a fascinating panel with really interesting folks, Kaiser, Care First, and Intermountain leadership. And I guess there was a clear consensus that we need to get a grip on cost, value, and some really interesting conversation about kind of how the organizations are doing that. I think the three takeaway points is that there's unsustainable cost. It's universal, it's all over the world. Sure. I see it globally because I work globally. For the first time in history, we're going to have data. We've never had data before. You know, we really tried to manage a population without data back in the HMO movement, and we really ended up not being very successful. And the third thing that's really driving this change, and there seemed to be broad consensus around that, was that we're going to be able to communicate vastly different than we used to, right? We now will have this, and you know, my kids who are in their 30s have never seen a teller in a bank, they never will. I mean, there's an expectation that in the travel industry, you're not going to have to drive to a travel agency anymore and get your tickets. In a bank, you're not going to have to drive to the bank to interact with banking, and that same expectation is beginning to happen in healthcare.
Okay, so we're moving really from this explosion of information in the information age to an intelligence age when we're using this data. What does that mean?
Well, first of all, I would say, thank goodness we're moving away from the information age into an age of intelligence. Because the information age has not done for healthcare what it's done for other industries. We are still a master builder, right? And the data depository is still here. We're still 100 to 1,000 years behind in our reading. And what the intelligence age will do as we move into the age of intelligence is that it'll provide at the point of care and be available so that we're not 1,000 years behind our reading. So cognitive computing, Watson can read the Library of Congress in 3 minutes, and it doesn't forget and it doesn't sleep, right? And if it's designed in such a way that sort of an idiot savant, right, where you have this information flow, and it does that really well. That's one stream that can help you. Another stream that can help you is it's really good at looking at patterns, right? So you can take a picture of a melanoma and compare it to thousands of other pictures that have been recognized by pathology as being a melanoma, and pretty soon it's better than the eyes of a dermatologist who only sees a few in their lifetime, right? I mean, so it begins to support and amplify and cadence that.
Okay. Now, what are some of the lessons that you've learned from traveling to other countries and looking at their health systems, and how can that be applied to what we do in the United States?
So I think the most important lesson that I've learned in travels is that there needs to be a system of care which is built on a trusting relationship with a healer who is your comprehensivist, who is your primary care provider. It's unethical, it's immoral, it's unacceptable to have 5 specialists all doing 5 different organ systems without any adult supervision. It causes huge harm. So in the Danish system, for example, which I'm very familiar with, I'm a healthcare ambassador there, no Danish citizen doesn't know the name of their primary care doctor. And no Danish citizen would dream of seeing a partialist or a specialist for a part of the body without having the support of that primary care system underneath it, right? So they've gone from, they've gone they've dropped the number of hospital beds just tremendously by really focusing on ambulatory care done in an ambulatory environment, robust primary care, follow-up, follow-through, integration, service. And then how do you pay for that, right, is another thing. I mean, so that's system redesign, designing towards robust primary care, first dollar primary care. But again, as I see payment change, the systems that work really well don't use only fee-for-service, don't use only capitation, but have multiple dials. So some of it could be fee-for-service for those services you want done in primary care. Some of it could be capitation. Some of it could be value you deliver the consumer, i.e. if I answer my emails in 20 minutes versus 2 hours, I get more money. If I have access on weekends, I get more money. So, you know, what is it you want out of the system? You begin to put dials in place to pay for that. Right. In one place that I first saw a pilot, they began paying the specialists to answer the email from the primary care docs. Boy, did that create a change in dynamic, right? Because all of a sudden that pediatric rheumatologist wasn't 8 months behind in their waiting list.
Right, makes sense.
You know, and so, yeah, there's examples of real progress being made.
Right, well, we look forward to exploring this further with you, Dr. Grundy, in our journey towards figuring out some answers. May I ask you, you've been to the meeting, this particular meeting before. What do you get out of it when you come year to year?
I really enjoy these meetings. It's really a chance to collaborate, to listen, and I guess the thing that's interesting to me is that you get people from the whole spectrum. You get employers, you get payers, you get providers, you get specialties from very different. You get physicians, non-physicians. I mean, it's a really nice mix of people that are attracted to this, and you know, I think it's a pretty interesting time for the consumers who take the time to use this conference.
All right, Dr. Grundy, thank you so much for your time today.
Thank you very much.
Appreciate the time. And I'm Mabel Jong. Thanks for watching. Stay tuned.